Hi, everybody, and welcome. We are right at 1 o'clock. We're going to get started very, very soon. We're just going to let people have a minute to move in from the waiting room into, or yeah, the waiting room into the webinar. So just bear with us for a quick second. Thank you all so much for taking time to be with us today. This is our August speaker series. We're very excited. Alrighty, so I think we are all set to go ahead and get started. First off, I want to give a thank you to our sponsors who you can see up on our screen right there, and a very warm welcome to everybody to our August speaker series titled A Conversation with a Physical Therapist for GBS, CIDP, and MMN. We will be focusing on this topic today. If you're looking for other information outside of this topic, outside of physical therapy, send us a message or an email, info@gbs-cidp.org or advocacy@gbs-cidp.org, and we'll point you in the right direction to get that information. In the meantime, in the right now, Maria Harris is joining us today. She's a physical therapist at Bryn Mawr Rehab, located outside of Philadelphia, so not too far from the office headquarters, and has extensive experience with GBS, CIDP, and MMN patients. Maria is a member of the Foundation's recently formed Integrative Health Committee, helping us guide our information and education about all of the ways to live well with GBS, CIDP, MMN beyond diagnosis. Before we start asking questions of Maria, a brief reminder that these webinars are meant to be educational and not meant to troubleshoot or consult on individual cases. As always, talk to your doctor, talk to your own personal healthcare provider about your care. If you do have a question about the topic we're discussing today, please type it in the Q&A box. But again, remember, we won't be troubleshooting specific circumstances or answering questions about specific medications you are taking or specific moves or things that you're trying to figure out. Please consider attending the symposium and signing up for a one-on-one conversation with our Global Medical Advisory Board if this is something you're looking for. And another quick plug for the symposium, Maria will be there in Denver at our patient symposium. And that's a great question, or a great transition to start our questions from Maria. Let me stop the screen share here, which, oh my gosh. My Zoom controls are going away. But Maria, while I get my Zoom controls back, do you want to give yourself a brief introduction or anything that I missed in the intro there?
I was going to say you did such a great job. I'm really excited to be going to Denver. It's my first time. So if anybody is from Denver and has any suggestions as to what I should see while I'm out there, totally hit up the chat. But yeah, I've been with the Foundation Help Volunteer almost 10 years now. So I've been very well versed with the GBS CIDP population. We've even had a few Miller Fisher. So if anybody on the call has Miller Fisher, I'm happy to help answer any questions to the best of my knowledge. But I'm just excited to be able to talk to you guys. It's one of my favorite things to do.
Oh, thank you so much. That's a great transition to our first question, which is, can you tell us a little bit about the role of physical therapy and the recovery or long-term management of GBS, CIDP, or MMN?
Yeah, so physical therapy, depending where you are in your onset versus like recovery phase, we have different roles, right? In the acute care, obviously, we're paying attention more from the medical stability and can you even tolerate sitting up without being on a ventilator? And can your blood pressure handle that? When you come to me, at that point, you have a little bit more medical stability. And we're really focusing on getting back to doing the things you used to do with maybe some modifications, whether that looks like an assisted device, braces, wheelchairs, walkers, if we're walking versus using a power wheelchair or a manual wheelchair. Our job is really to focus and promote that mobility and that strength back. I like to think of my home care therapist as the bridge between inpatient rehab and outpatient, right? You're not quite ready to be out in the community, but you are also too medically good to be in an acute rehab setting. So a lot of them are really focusing on how to maximize your independence and safety within the home. And then when you transition to outpatient, these are my fine tuners. They're the ones that are really looking to get that maximal recovery and trying to get all that little bit of residual left and to get you as close to 100% as possible.
So there was a word in there, or two words that I really like, the independence and the safety. So can you tell us kind of what does that mean from your perspective for GBS-CIDP and MMN?
Great question. So a lot of times patients will say to us, well, I just want to walk again. And I'm like, but you are walking. You may be walking with a cane or a walker or some other kind of device, but you're walking. So I think a lot of times people have this perception that walking is what they were doing before, whereas my standpoint is if I can allow you to get up and do things again, but safely, that's what I care about. Because if you're walking 10 feet, but you're tripping or you're falling, how is that any better than being able to walk all day with a walker and just doing more that you want to do in your day? So I like to break it down to people like that. It's not just about being independent and not using any device. It's what is truly going to make you better in the long run and safer.
Yeah, and what's interesting is I think there's an emotional health component to that as well. And we're not going to get into that there, but
Yeah.
that's a whole other maybe component to this is kind of understanding that where you are, being safe and independent might just look a little bit different than what you're used to. But if those are your goals, kind of understanding what can help you get to there.
Yeah, and I like to think of assisted devices as quote unquote a crutch, right? They're there to be the
Mhm.
bridge to keep you safe and independent. It doesn't mean you will always need them. It also doesn't mean you might not always need them. But I don't think we need to harp on in the moment that we're using it. It's just it allows me to do more, and that's the mindset I like to keep my patients focused on.
Yeah. So you mentioned the in the moment. So how long is a typical kind of course of physical therapy treatment for the patient community? Again, GBS might be different because it's acute. CIDP and MMN are a little more chronic.
Yeah, if we're talking about from like the very first onset to the end, we're looking at months worth of recovery here. Um, as we know, hospital stays are getting a little bit shorter, so maybe home care and outpatient stays are getting a little bit longer. But really, it just kind of depends on what each person's goals are. Like if you are younger and you want to get back to school or get back to driving and get back to work. We had a gentleman who had all those goals and he ran Spartan races prior to getting diagnosed. And he was in therapy for a good 12 months, but he's back to work. He's back to driving. He's back to doing Spartan races a little bit more modified and slower than what he was doing, but he was able to get those goals. There are some people who are like, I just want to get through my day, right? So they might not be in therapy as long as somebody else.
So it's really goal dependent is kind
Yes.
of what I'm hearing and where people are starting from, maybe.
Yes, absolutely.
Okay, interesting. So, thinking about that, what are the long-term benefits? So, even if we're just thinking of that standard kind of couple month treatment plan, are there long-term benefits that people are still reaping like a year later from doing physical therapy? Can you talk about that at all?
Yeah, so I love when people say, "Well, I did physical therapy and it didn't work for me." And then when I start to probe and I said, "Well, why didn't it work for you?" And it's like, "Well, I was really good when I was doing the exercises, and then when it stopped, nothing happened." So I like to tell people and remind people, we give you the tools, and when you leave us, you're supposed to continue to use those tools, right? So that's the nice thing is it never does end. It's your responsibility to continue to do the exercises and maintain your mobility and stay active to continue to see those long-term effects. And sure, you can come in and do like some tune-ups if you need to. Or if somebody gets a cold, sometimes we'll see a little like flare up, if you will, of some
Mhm.
symptoms. That's okay too. But if you have an established relationship with your physical therapist and they gave you a solid plan of care or a home exercise program for continue, you should continue to do that because that's what's going to keep you moving forward.
So, what about this moving forward? Sorry, I'm not wording this correctly.
No, you're
Is
fine.
there a benefit to when somebody starts PT? So let's say they don't start, right after their kind of stabilization medically, they start later. Is that too late, or are there still benefits that can be had from, taking that delay?
I think it depends on why there was a delay in gap. I mean, if it's just because of a medical standpoint, whenever you start is going to be good. Obviously, the earlier we can intervene, the better it is for recovery. So that's a little bit tricky to answer because it's like if you're just so sick in the beginning and you can't tolerate it, then there might not be anything worth to therapy at that point. But traditionally, we always say the earlier or the sooner the better, which is why you're seeing more people in the ICU getting more therapy.
Do you know why we say earlier the better? Like, what is the biology or physiology behind that?
So research is just showing, and it has shown over the last 10 years, that progressive mobility starting in the ICU actually shows better functional outcomes in long term. So whether that is decreased length of stays, shorter times on vent, when we're looking at more of that like medical stability piece of it, it seems that people who got physical therapy and occupational therapy sooner in the ICU, they tend to have better functional outcomes with shorter length of stays.
Yeah. We're getting tons of questions from our audience here, so I'm going to go through some of these right now. This one I think is really relevant is tips or input on finding a PT experienced with CIDP, but also realizing that there are hospital and insurance barriers and things like that.
Mhm.
So, any recommendations on finding somebody who is experienced? And then I will add a second piece to this. If they're not experienced, what can we do about that?
um, I think if you are, let's say you are stipulated to a certain physical therapy group or health system, I would call them. That's your first step. Sometimes you can even call your insurance company and say, like, this is my diagnosis. I would like a list of people that are familiar with my diagnosis that you would approve. And then I would call that facility and say, hey, this is what I have. Do you have a therapist that is familiar with this diagnosis? Usually, I would say a neuro type rehab place is going to be a better place. And there are people who, like outpatients, that are not just ortho specific, would be your best bet to do that. If you do not have that option, I would just educate them because all therapists have an understanding of what we're supposed to do. So it's not really diagnosis specific, right? So the training effects of what we should do. You never want to overexert or exercise to fatigue. That is the number one thing I
Mhm.
tell all my therapists that I am training or doing continuing education courses. So you want to make sure that your therapist understands that, okay? Because it actually might delay your progress or set you back a couple of days. And we don't want to do that, okay? So it should be low, slow, and increasing the intensity a little bit. Or so you would want to increase maybe the number of reps before you increase the weight, depending how your body responds. So
Mm.
those types of principles. And you just want to have an honest conversation with them because if you're really, really tired after a session and it wipes you out, and they're like, great, that's what I wanted. They're not your therapist. They
Mm.
don't understand. If you tell them and you say, that was way too much, they should be able to tailor your next treatment session so that you wouldn't have the same effects after. I hope I answered that.
No, that does make sense. And it sounds like that there is a delicate balance because you want to be pushing people so that they're kind of building strength, but we don't want to be at that point of fatigue that
Mhm.
people are feeling like they can't go on the rest of their day because they just ran a
Or even
marathon,
the next
essentially.
day.
Yeah.
Sometimes people get so tired that they're like wiped out and they have to sleep all day. Like, that's not what we want.
Research that's really published or anything that we could point to, as patients going to somebody who might not have that familiarity.
Um, I might have to find some articles for you. I don't know how much of it is research based versus principle based, that what we're taught in school.
Hmm.
But it's
Hmm.
just understanding that because anybody who works out and trains, essentially what we're doing is precipitating that inflammatory response. And that's the last thing we want to do with GBS and CIDP, since it is an inflammatory process, right? So they kind of just need to understand that we don't want to go to those levels.
That's interesting. I think that's maybe a key word that our patients, if they're feeling like their physical therapist isn't familiar, understanding that these are inflammatory diseases and that, what are some treatment plans that you might have for me that wouldn't overdo that inflammatory process. Does that
Correct.
sound right?
Yeah.
Yeah. I will mention too, well, you and I have talked about this, like really wanting to get some of that research published, and especially your techniques and the good work you're doing. So I hope that in the future we can do that. And I did want to mention that on the foundation's website, and we'll include this in the follow-up, there is a section on our website that links to an area or links to a website that does list physical therapists who do have some of the specialty expertise that Maria was talking about, especially in the neuro sense. But backing up a little bit, you talked about doing that PT to fatigue or over fatigue and how that's not good for you. And GBS, CIDP, and MMN patients often really struggle with fatigue, right? That's a very common symptom that our patients are talking about. At the same time, the research is showing that exercise is one of the best things to do for fatigue. So, do you have any ideas to find that balance of exercise or any reactions to that
Yeah.
suggestion?
So there is something that we teach here with our patients, and it's called the spoon theory. And actually, it was introduced to us by one of our speech therapists who use it. And if anybody is familiar with the spoon theory, I hope you are using it. You can put it in the chat if you are. For those of you who have never heard of it, I'm going to try my very best to simplify it. But you want to think about your day as starting off with, let's say, 10 spoons. And if it's a day where you're taking a shower and getting ready to go to a doctor's office, and let's say getting ready and taking a shower takes 2 spoons out, okay? Now you have 8 spoons left throughout your day, and how are you going to use those spoons to get everything done? Okay, so I like to put that into perspective of the same thing when we're exercising. So I tend to keep it very functional based for my patients and say, okay, we need to exercise and progress, but you also have all day you have to get through. So maybe I'll only use 1 spoon or 2 spoons, depending on what we have planned on the agenda. But that way you still have spoons left over to do everything else you need to do. So whether that is walking 30 minutes 3 times a week and you use more of your spoons that day to incorporate your fitness level. Maybe you're at a point where I have somebody who wanted to get back into marathon running. And now she's running the Broad Street, what is that, 10 miler? Chelsea, I think, is
Yeah.
Broad Street. So she's up to doing 10 miles. And it took her a while to build herself up. And her training days were very specific. If she knew she was going to have a longer, like, running day, she would use her energy to do that and then planned, the rest of her day or days around it to not use as many spoons. So I think it's an interesting visual concept on how you exert your energy and how you spend your energy. So I hope that helps for people.
It really does. And I think it's putting in perspective to me about how important this relationship is, that you, the PT and the patient need to have a lot of trust and communication with each other. And I'm assuming from your perspective, you have trust in the patient that they're telling you if this is too hard, too strenuous, doesn't feel right. And the patient is trusting that you are listening to them and knowing that they know their body best.
Yeah.
Those are some of the ideas that came to my mind.
Yeah, because honestly, we're not mind readers. We get to know our patients, but we're in inpatient rehab. So sometimes we're with you for an hour and a half a day, and we can start to read your body signals. But if I'm an outpatient therapist and I only see you for an hour, maybe 3 times a week, it's kind of harder to like gauge how you react because I might be seeing you at the best part of your day, right? So if you're not telling me how you're feeling the other 23 hours in the day, it's really hard for me to tailor the plan of care and make those adjustments. So you have to be super honest with your therapist about that.
And you've mentioned tailoring a lot too, that this approach really should be tailored for the person, for where they are, all of that.
Mhm.
How do you assess that at the beginning?
That's our job. I wish there was like a magic, we start with A, B, and C in recipe. But that's just what's kind of for me, and I'm sorry for the people who are living this, and I'm going to say I'm excited to work with this diagnosis. But it is, every single person is very different. You have somebody who might need two people to sit up, and then you have the extremes where I have people who end up running 10 milers and Spartans, right? There's a huge variety of people, and you just have to meet people at where they are and where they want to be and know how to scale it that way.
And it sounds like that applies GBS, CIDP, MMN, Miller Fisher.
Really, any diagnosis, but yeah.
Yeah, yeah, that's
But
true.
yeah, so, am I going to do the same intervention for somebody who's in a wheelchair compared to a runner? Absolutely not. But I also need to make sure that the person who is sitting in a wheelchair can still perform their weight shifts and be able to stand up or transfer, and make sure that their day and they're strong in that mobility.
Mm, yeah. We're getting a couple questions about that over exercising and that inflammation link. So, do you mind just kind of repeating some of that, the dangers of over exercising or straining too much in your exercise?
Yeah, so depending where you are in your recovery, everybody's exercise regime and tolerance is going to be a very different, right? But the principles are all the same. We do not want to exercise to fatigue or overexert. And the way you would know that is your body will tell you the next, later on that day or the next day, you won't be able to do anything that you normally do and you're just so tired. Okay. So that's your body's cue of I overdid it and I need to back off. I hope that helps
For
answer
sure. And
this.
there's an inflammation piece of that, right? Because CIDP, GBS, there's already inflammation going on with the nerves and the immune
Correct.
system.
So essentially, when anybody's training, when we are building muscle mass, we're creating micro tears in our muscles, right? And those micro tears to build muscle cascades the inflammatory process. Okay. I don't want to give a whole anatomy and pathophysiology because we don't have that time. But that's essentially what's happened down at the muscular level when we are doing training. Okay. The last thing we want to do when we have an inflammatory process is encourage more inflammation because what I like to say is GBS, MMN, all the variants, you guys have different rogue antibodies that get triggered by the inflammatory process. And those antibodies is what attacks that myelin sheath. Okay. Now, the your diagnosis is dependent on that rogue antibody. But essentially, they all do the same thing. They destroy that protective myelin sheath, that fatty layer that protects the nerves, and send that electric pulse that, the message from the brain to the muscles to say, I need you to open my hand or I need you to do this, wherever it is. Okay. So if I'm causing more inflammation, I'm just going to trigger those antibodies to attack more. I don't want to do that. So that's the whole biology behind it of how do you progress somebody and work them, but also not trigger that inflammatory process.
It's a great balance, exactly like what you were saying. And I think it really speaks to the importance of that whole person care of the medication that is helping to reduce that inflammatory process, the physical therapy to get the function back, the safety and the independent living, and all of that build up the strength to be able to do those things. So we're so grateful that you are in our circle of care and part of our integrative health committee. And then we know that there's other pieces of that too, the emotional health and the nutrition. And we could go on and on about all of that, but
All of
we'll
it.
we'll
All of
focus
it.
on
Yeah.
PT today. So we've talked a lot about the diagnoses, but what about age? Does that play a role in the program, or exercises that you might recommend?
I don't necessarily look at age. I mean, age is kind of a indicative factor of whether somebody is going to progress better or worse. But I will tell you, I've had people who have been 40 years old, and I've had people who are in their 60s and 70s, your typical presentation. And In my phase of recovery, I'm pretty much doing very similar activities, right? Because my goal is to get you home as, again, independent as possible. I think where that may come into more effect is, again, what are your goals after life with diagnosis? Do you want to get back to driving? Do you want to get back to work? I think, younger, we recover a little bit faster. I don't think there's true research on that, but that's what people say. Um, but just like anything, like if you have diabetes or, the older you are and you have diabetes, the longer a cut on your hand might take to heal as compared to if you're 20 and don't have diabetes, right? So, I don't think age necessarily dictates our plan of care. I think it depends on where you were and where you want to be and how motivated you are.
Really individualized, it sounds
Yeah,
like. Yeah.
yeah,
And again, this importance of the partnership and of the patient kind of speaking up, talking about how their body feels and all of that, and you reading the signs that you can and tailoring that approach to the person.
yeah. Because like I
Um,
said, the gentleman who did the Spartan races, he's almost in his 60s. So, he probably wouldn't have anticipated that, but he's maybe like 5 or 6 years away from retirement and he still wants to get back to doing all those things.
um, what about on the opposite end of that spectrum, somebody who might be stalling in their progress in physical therapy? Do you have advice or programs or moves that you might start to pull out if somebody really is hitting a roadblock in getting to the goal that they want to get to?
I think it depends on why they're hitting that plateau. Um, is it because of something medically that's going on versus mentally or emotionally? I think those two have very different, if it's more of a medical reason, I might have to send you back to the neurologist and look at medications and dosing and figure that out. If it's more of an emotional block, mental health, maybe you do need to take a break. There are some people who are just tired of being in a hospital or being involved in healthcare and just need that break. And that's okay too. So I think it's just the importance of what's going on and why is this happening. And again, tailoring it to make it salient for that person.
Mm. And I imagine this applies GBS, CIDP, MMN, and the variants as well, that, it could be any of those factors as to why, even if somebody has recovered from GBS, you might send them back to the neurologist.
Yeah, especially if like let's say they're with me and they're walking 50 feet and all of a sudden they can't even stand up. Well, that's a big change. What's going on, right? And that's usually one of the flags that we don't waste time with this population and we usually contact the neurologist immediately and say like, "Hey, this is what happened." And usually most neurologists want to see them back because they can get them on their course of IVIG or steroids or do some kind of plasma exchange. Because generally speaking, when you have a big medical change like that, it's usually because there is some kind of like flare up or it's causing that inflammatory process and
Hmm.
they want to, catch it before it gets even worse.
Yeah. And like you said, there are some, especially with CIDP, maybe the chronic side of the CIDP and MMN, there could be some just kind of everyday life triggers or colds or flus that could
Mhm.
be triggering that. And so, if we're thinking about these chronic patients, are you taking one maybe not so great session as a major sign, or would you encourage patients? Like, let's see how next week goes. And, if you're still feeling this way, then we might investigate more.
I still tailor and change my chronic folks. I'm thinking about my one gentleman who came to me, he had a stroke, but his CIDP got flared up because of that, right?
Mm-hmm.
Um, and unfortunately, the medication that he was on was not FDA approved. So he could not continue his dosing while he was here. So that was a really interesting scenario because we had to figure out a, was it the stroke? Was it the CIDP that couldn't be medically managed? And what did we do about it? So I think, even with the chronic phase of it, if there is a big change from just baseline, we all have a baseline. So anything that is a big deviation from baseline is immediate grounds to go back to your neurologist and talk to them. I think if it's something smaller in the sense of, I was up all night. I didn't sleep well, and now I can't stand as well today, but you're still able to stand. That's not as much of a red flag for me, right? Because
Hmm.
there's a very specific agent, or um, his wife ended up getting a cancer diagnosis while he was in rehab and was very stressed about it. And the following day, he was just like, I'm just really tired. I have this on my mind. Well, I could attribute that to a very like specific event, and that stress, caused that. But you always see some kind of level of getting back to where you were. It's
Hmm.
when you don't see that upward climb again that you're really concerned.
Yeah, interesting. And I think a common theme here really is just patients having these conversations and maybe oversharing a little bit about what's going on
Mhm.
because it sounds like you as the PT want the whole picture
Yeah.
of, how is everything doing? Is there something that's affecting you today and your progress, or are we looking at something else?
Yeah, absolutely. Because, our chronic friends, fatigue is a big issue, right? And if you don't sleep well, I can't expect that I'm going to get the same thing out of you as the day before.
Yeah, absolutely. On the other side of that, so how do you as a PT know when somebody doesn't need physical therapy anymore?
Generally, I feel like people hate us in the beginning and then they don't want us to go and we have to rip off the band-aid, right? And I don't know how many people feel like that because it's kind of scary after you develop a relationship with a therapist, and you're like, oh, but I do so good with you. But I think it's just, again, having that meaningful relationship and showing them. I tend to like having one or two sessions before they're going and saying, go ahead, do it. Show me what you can do, right? And give them that confidence, so they know that they are prepared and they're doing it. But the beautiful part, especially when you're an outpatient therapist, you can always reach out and contact your therapist if there is like a question or you have, oh, hey, this exercise is easy. What can I do to make it a little harder? Or just have those conversations even before you leave. So that way you know how to appropriately progress those exercises if you get to that point.
And then, yeah, so after that, are there any things that you regularly prescribe for people to do at home, once they graduate?
Yeah, like I said, I keep my exercises tailored to be more functional. So, one of my favorite exercises is sit to stands, like literally every hour. If you cannot walk, I just want you to do 10. And I don't care if you have to do two and then you stop and you break, but I want you to do 10 sit to stands every hour. Very low, risk, no equipment involved other than a chair with arms. And I want you
Sturdy
to do
chair, I
that.
would say, not my roller chair,
Yes, a sturdy
right?
chair, not a rolly chair or anything like that. And a lot of times I tell them too, like if you're walking, I want you to get up and walk. Just do like a lap around your house, whatever makes sense. And if that feels good, the next time add 30 seconds if you can, or just add 5 seconds at a time, like whatever feels good to you. And then just make those small increments because over time, those small increments is what will add up. So usually when I'm building a program for my patients who are starting to walk, I'll say, if I know they're walking for a minute straight with me, we'll say, like every hour, I want you to walk for a minute. And then the next week, I want you to add 20 seconds. And then if that feels good, great. Add another 10 seconds on that, right? If it doesn't feel good, back it down. Only do 5 or 10 seconds, right? So I give them a little bit of a range so that they know how they're feeling. But ideally, every week, I'm increasing them to by 5 or 30 seconds to the point when they get to 30 minutes consecutively. And a lot of times people can do that, especially if they're doing it every day during their waking hours.
Hmm, interesting.
Mhm.
Um, this question comes from the audience and maybe is a little complicated, and I might reword it a little, so I'm just throwing that out there for our audience. But so PT, are you focusing on the whole body or are you focusing in on where people are having issues, such as like the feet, the hands, things like that?
Generally speaking, we are focusing whole body.
Hmm.
Um, but not to say that we can't have a particular interest or focus on the feet or the hands. I think in outpatient, it gets a little bit different. In inpatient, because we have PTs and OTs, that seems to be where we segregate the body a little bit more. But in outpatient, if your physical therapist is very familiar with the hands, there's no reason why they couldn't focus on your hands, especially if that's an area of focus or need or a goal to do.
And the second half of this is if you are kind of focusing on some of that, are you also then focusing on strengthening other parts of the body to help that affected part of the body? So, for example, like, are you doing back exercises that will eventually help strengthen the wrist and like the hand gripping movements?
Yeah, so we tend to we have actually are building a whole course on the trunk. And really what we always strive to say is if you don't have proximal stability, you won't have distal mobility, right? So making sure that our abdominal musculature, our back muscles that hold us up are nice and strong. That's like where we tend to start because it will be hard to see any kind of good function in our arms or our legs if we don't have a good core or posture to hold us.
So when you say trunk, kind of like neck to hips strength and
Yep.
all of that core, front,
And back.
back.
Yep. Front, back,
Yep.
sides. Yep.
This sounds like a little bit of an endorsement for Pilates.
It, I mean, I'm not going to say Pilates or yoga or, any of those type of things. But yeah, I mean, I think a lot of people don't really focus in enough from their neck down, right? You see the big people with the big arms or, the little legs or the big legs. But we kind of neglect from our chin to our hip area. And we really should focus in on our core because that's really the basis of all mobility.
Very interesting. The basis of all mobility. Can you expand on that a little bit more?
Yeah, it just goes with that. Again, the principles that we're taught. It's, proximal stability gives
Mhm.
us distal mobility. So if I'm like loosey goosey and I can't hold myself up, well, I can't really use my arms or legs appropriately. We have to be able, that's the whole how we were, I guess evolution was to be able to stand up against gravity so that we could use our hands, that we can use our legs to walk. So, but if we don't have that, I always tell my patients, see, you can almost see what happens when I look down, everything drops with me because
Hmm.
our bodies follow what our head is doing. So if we're able to hold ourselves up, everything just lifts. And we have to face gravity, right? All day long. After a while, you sit here and you start to sink. That's gravity playing onto us. So if we have a strong musculature of our core or our back muscles to hold us up, we'll just have better posture and better use of our arms and our legs.
So I know we're not giving any prescriptions here for PT, but is there anything, other than kind of fixing that posture, anything people can be doing to be thinking about all of that core and that proximal or that trunk control?
Yeah, I think just working on your posture, there's a lot of very simple exercises you can get online for postural realignment. If you are into yoga and Pilates, I think those are fantastic because they really do focus in on those tiny little muscles. But you can also do them in sitting. So that's
Mm.
one of those exercises that is good for a lot of people, depending where you are in your levels. And then if you're on the higher level side, you can even do the like Pilates reformers and get your whole body involved, right? And progress that way. Um, but even swimming, getting in a pool if you have
Mhm.
access to that, and just working in a pool, which is a little less stressful on the body because you don't have to hold your weight up as much. And there's plenty of buoys or pool noodles or like backboards and things like that. Just being able to even hold yourself there is a great place to start.
That's a popular one, the aqua therapy that
Mhm.
I think I've heard a lot of people really like and appreciate
Yeah.
too. So
And
something to consider.
I know there are a lot of people all over here. If around you guys you have equestrian, that's another big thing. Horseback riding, that's another great one for those who like to get on horses for that trunk and posture.
Interesting. Very interesting. There was a question in here. I think I lost it, but it was specific more for the um, AMON version, the AMAN version of GBS, which is more characterized by some of that axonal damage of
Mhm.
GBS. So, like a really severe GBS. Do you have
Yeah.
any experience or just any reactions to how you might help somebody with that condition?
I have not had an experience, but I think my treatment plan would be different, knowing that it is more at the axon level and not just the myelin sheath. Unfortunately, I think those, and you can correct me if I'm wrong, Chelsea, but I think those residual deficits are more lasting just because it happens at the axonal level. So again, I think in that scenario, I would treat what is in front of me. I still using the similar principles of not going to fatigue and things like that, but I think depending on the presentation, I would tailor my goals a little bit more differently than I would with somebody that I know it's more of an inflammatory type issue.
Yeah. Similarly, on the CIDP side, if there are some kind of permanent damages or things that sometimes we call residuals, things that aren't being corrected by the IVIG or steroids or anything like that, um, is it similar? You're still just kind of looking at what's in front of you, or do you have any recommendations or thoughts on that for
I think
CIDP, the
with
chronic side?
I think for like CIDP, the idea is to kind of get you back to where you were before we dropped off, right? Like we always have like a little bit of a plateau and there's still that upward movement. Um, I I think with the AMN and excuse me, version being the axonal, there's just not as quickly recovery. I don't know how much of the up we would see. Um, and that's something I don't have experience with. So I hate to like give false hope or anything like that, but I would just imagine I would need to work with more of the PM&R doctor and the neurologist to really understand the extent of damage there and what that prognosis would look like to be able to tailor. Now, not to say that like you can't have recovery. I just don't know how quickly that would be in comparison to somebody with like GBS and like CIDP because that's happening more at the myelin sheath and not necessarily at that axon level.
So it sounds like you would want to assess with the doctors kind of where that damage is and what their realistic goals are for progress,
Correct. Yeah.
and then work with a patient to get to those realistic goals. So they just might be different than the standard GBS.
Yeah, and it's hard to know too because I would imagine more people would probably have EMG studies to kind of know and understand how much nerve damage there is there too, and to have a more clear expectation of return.
Yeah, yeah. Another variant had popped up into my mind, and I think somewhere in the chat that I saw was anti-mag. And that presents a lot with some of that feet and the sensory issues in the feet. Any experience or thoughts on that one?
No experience with anti-mag, but I will tell you a lot of our other patients also have a lot of hand and feet sensitivity. And this is something that I'm working with one of the global medical advisories on and looking at heat because we have tried some heat and we've had some really nice success with it. So more to come on that. I'm hoping that's probably one of our like research topics that we can explore a little bit better. But I have found that my patients who have a lot of hand sensitivity, a lot of feet sensitivity, will sometimes start with just moist heat on those areas, and it just makes them feel so good and it dampens those signals, and then they're able to like walk or stand, and it's not that biting, burning pain. And then over time, that tends to diminish. It's kind of hard to know if the heat is helping with the inflammation and it's causing some neuro recovery. But it makes them feel good, and that's what I like. So
Yeah. That's good enough for now, and then we'll
yeah,
figure out the biology after.
exactly. Yeah.
Absolutely. We had a question from the audience about oxygen. If you ever use kind of like supplemental oxygen in PT, with the specific question, does it help to wake the nerves up or wake up the nerves?
The only kind of oxygen we're using is if you need it to breathe. So I cannot speak on that at
Yeah.
all.
It sounds maybe like it was a personal experience, and I'm
Yeah.
glad it works for that person. But I think, again, the importance of tailoring these approaches to the individual and what they need at that time is so important.
Yeah.
Yeah. There was another one. So we have patients who have multiple conditions and things going on or complications from their therapy, like anemia is one that might pop up, things like that. Does that does that come into play? So it's not just a GBS patient or it's not just a CIDP patient. We're again looking at the whole person and things like that. So how do you manage these kind of multiple conditions and also then who becomes like the point of contact? Is it still the neurologist or are you looking at other specialties
Yeah,
as
see,
well?
I'm very fortunate because being in inpatient rehab, I have doctors and nurses literally at the palm of my hands. So if a patient is more anemic, depending on their levels, we tailor again our intervention to maybe be even less. Um, Intense than we had normally planned, right? Because the last thing I want to do is continue to drop your hemoglobin. And usually, my nurses and the doctors that are here are investigating as to why somebody is anemic. Is there some kind of GI bleed we need to worry about and things like that? So they'll handle more of that medical piece where we will change our intensities for therapy and maybe we just do bedside treatment and you're just in bed and we're focusing on range of motion, straight strengthening in bed and stretching. Right, we always make a goal, or maybe we just work on rolling transition and getting your core involved. But I'm definitely not going to stress the body and have them stand and walk if somebody is a little bit more anemic and I take the chance of them passing out on me.
Yeah. Again, this tailored approach, but I'm also hearing that maybe there's a benefit in, especially in the US, we have health systems and people's neurologist is probably associated with a health system. Do you think most health systems have a physical therapy kind of component. And I'm hearing that there might be a benefit because then it's an easy conversation between the physical therapy and the neurologist versus if you're maybe separated, not in the same electronic medical records and things like that, it might be a little more difficult.
I think it's easier when you're in because I can just hop onto my electronic medical record or and add my doctor that's in-house as well as the neurologist and everybody's on the same page, right? But you can, as an outpatient therapist, you can always call the office. There's always like a nurse practitioner or a PA in the office, and you say, I'm calling from a doctor's office, and it gets the message through. Maybe not as quickly, but I think, your therapist needs to do their due diligence and make contact with the neurologist. Because again, it is a very much team approach, and your neurologist also can't help you if they don't know what's going on, and maybe they only see you once a year, whatever follow up if you're even following up with them at that point. So,
Yeah, I think that's really important point actually here is that the PT shouldn't be working kind of on an island and that you're working with the patient, but you're also in contact with the doctor and understanding their perspective and things like that.
yeah.
Yeah, so there's something for patients to keep an eye on and making sure that you're advocating for that from your PT and from your neurologist. Sometimes
Yeah.
you might just have to give them a gentle nudge.
Yeah. I like to say it's a moving target. So,
Yeah, exactly. Jumping back, you talked about the moist heat for the hands and feet.
mhm.
Can you describe what that means?
Oh, yeah. So, what we have here, it's called moist heat. So they're like thermal hot packs that sit in a hydroculator, which is like a hot water bath. And usually the temperatures are about like 120-ish, maybe a little lower. So they're pretty hot. And then we put them in layers of thick towels and like padding. And then you're not supposed to like lay on top of them. Usually you drape the extremity over top of that with like 6 to 8 layers, sometimes a little bit more with this population because of the sensitivity. And generally speaking, we keep it on for about 10 minutes, could be a little less, could be a little bit more, just really depends on the therapeutic effects we're going for. Um, but we're constantly checking the skin, just making sure no one's getting burned, that it's increasing the sensitivity. But generally speaking, it's a topical heat that is going at surface level. But again, I'm curious as to doing a little bit more research and seeing what's actually happening below the skin. But it tends to calm things down at the surface level. So what I've been finding is I'll put patients' feet like right onto it because it seems like the bottom of their feet and toes are the really like tingly parts. Some people I will wrap their hands like into it, almost like if you've gone to a manicure, gotten a manicure done, and they wrap your hands with like a warm towel, kind of the same effect. And I let them sit there before we start our therapy session. We've had one gentleman, our Spartan guy actually, when he came in, he had like bilateral wrist drop, and he was so swollen he wouldn't even let us touch his hands. And we came back from the symposium after talking to Dr. Castro, and we're like, can we try this? Like, can we please just try it? And he let us try it, and instantly he went from being here to then being able to do this. Just removing the heat. And then every day he was like, I'm in. So every day we did it, and now he's back to driving. So he's a little bit like this, and we've done more like splinting with him and things like that, but he's back to work and he can use his hands. So whereas he was like stuck like this and wouldn't even let you touch. So some nice recovery there.
Yeah, absolutely amazing. And I want to throw out that if this is something somebody is interested in, please talk to your physical therapist about this. Don't try to recreate this at home.
Yeah.
Definitely do it under supervision. And if your physical therapist isn't aware of them, ask them to do some research and look into this a little more. But just please don't try to do this at home. We don't want
Yeah,
any
or they
burns
can
at the facility.
contact me because I don't know how much research is out there, to be honest with you. But I'm happy. I'm sure my name is on the website at some point. So I'm at Bryn Mawr Rehab.
Thank you for offering. Yes, we're happy to connect your physical therapist to Maria for the whole how-to if this is something you are interested in. So we only have a few minutes left. We've talked, symposium is coming up. I wanted to chat about any tips that you have for our patients who are traveling, because traveling can take a toll on the body. You're sitting in that airplane seat. Any kind of things, stretches that you recommend for people who are getting ready for a trip?
Um, yeah, I mean, depending on the flight time, obviously sitting and the risk of blood clots for a prolonged period of time is very high. We talk to your doctor and see if maybe like a type of compression sock on your leg is appropriate. That tends to be a first go-to. If you have the ability to move your ankles up and down, being able to do ankle pumps. If you are not able to do that, you can do even like sitting marches in your seat. Just keep yourself moving. I would say maybe every hour, as hopefully you have aisle seats and you're not annoying anybody. But get up, and even if you don't have to go to the bathroom, just like walk that little bit of the aisle up and down. Again, just movement is the key. I always like to, and I do it myself, like before I get on the plane, I like to go to the bathroom. When I get off the plane, I make it a point to go to the bathroom, even if it's just to stand or, use the facility. I, stretching is not necessarily, you're not going to get that tight that quickly those hours. It's more the key of getting up and moving.
Yeah, just keeping that blood moving and not letting
Yeah.
those muscles sit too long for sure.
Yeah, so usually like right before I get onto the plane, I'll purposely go to the bathroom just so I'm walking a little bit right before I'm getting on. So,
Yeah. Awesome. So things to do at home. We had talked about that sit to stand, but is there any kind of other movement or exercise patients should think about after their therapy ends? So like, are there any like free YouTube channels that you recommend a lot or at-home exercises? Just anything for people at home who are looking to continue their progress.
I don't have any like specific YouTube channels. I think for the people that are standing and are still having complications with their feet. There's exercises that I like to recommend for short foot. And you can look them up on YouTube and kind of do short foot exercises. This really helps with those ankles and those small muscles in the feet. I like to do those, but realistically, and like I said, if you're involved in like yoga or Pilates, fantastic. If you're doing aquatics, amazing. But really just getting up every hour and just if you can tolerate it, like I said, either the sit to stands or the walking. That's truly what I recommend.
Yeah, and you focus so much on the function. Can you talk a
Mhm.
little bit about your OT counterpart, what OT is, and then kind of how that complements your work?
Yeah, so people like to say, well, what's OT? Like, I'm not going to work. But we like to say we help you get there, and then they're the ones that help you figure out what to do when you get there. So they're working on more of that fine motor coordination, getting dressed, doing buttons, getting ready in the morning, how to make a meal or how you're cooking, those type of activities, taking medications, managing your pill boxes, little pincer grasps for medication. So I think even though OT is a little bit different, they're still focusing on function. It's just in very different forms of, getting ready and what else you have to do throughout your day.
And OT stands for occupational
Occupational
therapy.
therapy. Yeah.
Yep. So again, really, it sounds like if we had to recap, it sounds like our physical therapy goals are meant to be individualized, no matter the diagnosis, GBS, CIDP, MMN, or all the other complications. And I would also say that this needs to be a really strong relationship between the PT and the patient, and then also with the doctor, making sure that everybody is on the same page about what the goals should be. And then it's really the PT's job to help you get there in a way that you can start to be safe, independent, and not over-exercised or overstrained throughout the day. Anything else from our summary that you wanted to add?
No, I think that hits it all. I think, going back to the devices, I always just try to encourage people like you are walking, you are moving. I'd rather have somebody walk with a walker or a cane with good mechanics than like, limp or have this weird little walk to them without it because they can do it, right? Again, it takes more energy to do that than it does to walk with a walker. So I think we just need to change our like mindset on these devices and how it's going to actually help us with energy throughout the diagnosis and allow you to do more of what you want to do.
I really appreciate that you mentioned the energy and the alignment. Those are so important things to be able to get back to where you want to be. And even, short amounts of time out of alignment or using all of that extra energy, do you think that hinders progress?
Absolutely, because our body learns, bad habits faster. It takes a lot longer to develop good habits than it does bad habits. So,
Yeah. So don't be shy about the devices. And a final plug for the symposium, there will be a whole kind of adaptive device area to learn about some more of these. And I'm sure, Maria, I'm sure you'll find yourself over there and checking some of that out. And I encourage everybody else to.
yeah,
So
and I
we're
think at the symposium, sorry, Kathleen and I are going to try to get different products for like more everyday things that help, so people can actually try it out, and like we can work with you guys on like maybe that more of that fine motor. So it won't be a presentation style; it'll actually be kind of like a mini session, if you will.
I love
So
it. And Kathleen is your OT counterpart, right?
yeah,
Yeah, so we'll get the whole package at the
yeah,
symposium. So that really brings us to the top of the hour. Maria, thank you so much for
yeah.
this
Loved being here.
conversation.
Yeah,
Yeah, this has
thanks for
been
having us.
super informative. Just a final reminder, if you do have additional questions, I'm sure Maria, if you're okay, if I send you some, if we didn't get to, if people still have questions, the email addresses should be up on the screen now, the advocacy at gbs-cidp.org. A reminder of our symposium that is coming up in less than 2 weeks. If you haven't registered yet, I highly encourage you to do so. A final thank you to our sponsors. And then again, there's so many next steps that if you are interested in being more involved with the foundation, please get in touch with us for opportunities to volunteer, other events to attend, or things like that. And also, if you like this program, we really rely on the generosity of our donors to help keep this free. So please consider making a donation. All of this information, plus a summary and the video recording of this conversation, will be shared after the fact. Just a final thank you to everybody for joining us. I hope that you will also be joining us and Maria at the symposium. Otherwise, we will see you next time for our webinar. And Maria, thank you so, so much.
Yeah, thanks for having me. I hope everybody enjoyed this.
Yeah, I did.
All
I
right.
did. So thanks.